Okay, so welcome once again, sir. And now we'll start our proper conversation with you. And I'm really very much thankful that you have joined here and you are with us. So, sir, first question which I just want to ask you that hysteroscopy has transformed the way we approach intrauterine pathologies. And what is your opinion that how it has become a game changer in gynecology?
Well, back again, Pratibha, it's very thrilling to feel that despite we are 1,000 miles away from each other, but we can talk and speak and share emotions as well. So I'm very glad that while I'm sitting in my office in Cairo, I feel that thousands of beautiful colleagues in lovely India are healing us. You touched a very important area in the human body, which is the uterus.
Yes.
Pratibha, I want everyone to stop looking at the uterus as a part of the female genital tract, which has certain function and full stop. No, I feel very jealous from cardiologists, from urologists, why we highlight the heart. Okay.
Yes.
Well, come on. You need a heart to live. We need the uterus to continue humanity. So, no doubt, after this introduction, no doubt that endoscopic surgery had done a revolution in the practice of medicine. In the past, diagnosis was by crude, primitive methods, percussion, palpation, and then came the technology of X-ray, which gives a black and white shadow. And then even the latest technology of ultrasound, all these things doesn't let you see and touch the tissues. Endoscopy allowed us to enter body cavity. So laparoscopy was very attractive, glamorous. And Pratibha, I will explain to you now something very important. Why laparoscopy development was very fast, while hysteroscopy was very slow, like a turtle. Because exploring the abdominal cavity was much easier. It's a big cavity. And the pneumoperitoneum with carbon dioxide allowed that the surgeon can enter and see and look to the organs that he already have seen it before, because you do cesarean section, you do hysterectomy, so you know that this little thing in the middle is uterus and this white things are ovary, so there is no confusion. You are playing in your playground, okay? But the cavity of the uterus stood for a long time, that mysterious cave, which difficult to enter, difficult to explore, difficult to identify where I am. The cavity is small and the uterus is a muscular, vascular, contractile organ. So creating the space was not easy. So let me tell you some surprises. You know, I will not tell how old I am, but I am the same age like Prakash Trivedi, Hafiz Rahman, Rakesh Sina. This is my batchmates, okay? All of them, they started by hysteroscopy. Maybe this will surprise for you. They all started by hysteroscopy. You are young. You don't maybe remember there was an iconic figure in Mumbai. I recall her name was Dr. Nargesh Mutashawa, something like this. Mutashawa. Okay. Yeah. She was the first to bring hysteroscopy in India, and we all tried to look, but all of them were frustrated. They see nothing, okay? At that time, Pratibha, there were no cameras. I feel embarrassed to tell secrets, to tell how old we are, okay? At that time, there were no cameras, so you work like this, okay? For laparoscopy, you work, yes, we work standing with pneumoperitoneum, so you can see well. But for hysteroscopy, you have to kneel on the ground and to look to the telescope. And at that time, the distension was carbon dioxide. So we see nothing, only bubbles and mucus and blood. So these are the reasons that many of the beginners, they dropped hysteroscopy and they became stars in laparoscopy.
Yeah.
So I think that once we could see the uterine cavity and identify, Pratibha, the endometrium is an organ by itself.
Yeah.
It's not a small layer, okay?
Yeah.
So gynecologists were able to know what kind of is it normal or proliferative or secretory or hyperplasia or a polyp or a myoma. We could explore another word.
Yeah.
So I can say hysteroscopy opened the door for a revolution in the practice in gynecology to explore the mysterious cave, the uterine cavity.
Yes. So very rightly said, sir. You said that it is, it was very frustrating. Even when I also started, it was very difficult to inflate the cavity. That was the biggest problem which we used to have. And we didn't have histojet and all those things at that time. So we started with the blood pressure cuff and all those things we used to start and we used to do with to inflate the cavity. And but do you think what are the now key advancement in the hysteroscopic technologies that has significantly improved the patient outcome? Because now people are adapting hysteroscopy and they know that how important and how easy it is to do it, because we all are a gynecologist and we prefer to go through vagina, and I think that is the safest route which we feel that this is for our mode of doing any surgeries. So if we can, what advancement in hysteroscopy has been done, which has improved the use of this hysteroscope now and has popularized this technique now?
There are three essential developments in the history of hysteroscopy, which make it now very popular. Number one, the instruments, the telescope, the sheath. Initially, everybody was using the urology telescope. Even some, if you visit some old hospital, they still have the old, which was rounded sheath, large diameter, and the telescope was 0 degree. So 0 degree, you can see front. You cannot see the lateral wall.
Yes.
Large telescope makes the insertion difficult. And when you try to insert, you do friction, you do shreds, and you do force track.
Yes.
So the great development in the instruments is the diminution, decrease in the size of the telescope. And maybe some doctors say, come on, Osama, the telescope in the past was 4 millimeter. The new one is 2.9. Is 1 millimeter make a difference?
Of course.
For the simple mind, they will say not big difference. But actually, between 2.9 and 4, it is 30% decrease in the diameter, 30%. So if I apply this on a body weight of a person, if a person is 70 kgs body weight, if increase 30%, he will become 92. So you see big difference. So the diminution, the size, and the shape of the sheath, the older shape was rounded. The internal os is oval shape. It is not rounded. It's oval shape. So the rounded sheath was not going easy. So all modern sheaths now is oval shape. So the diminution, the size, the change in the shape allowed easy access. And I always say it in my training, the success is in the access.
Yes.
The access by laparoscopy is easy. You push the trocar, you're in, okay? There is no much effort. But in hysteroscopy, you have to drive in the dark, in that tunnel, from external os through the cervical canal, which has sometimes curved ways to the internal os. This journey is difficult. So diminution of the size, this is, and change in the shape, this is number one. Number two is distension. Since the invention of laparoscopy, there was no much debate. It's only carbon dioxide, and the pressure used is 14 to 15. You will not find any fight between doctors to choose between the type of gas or the pressure. In hysteroscopy, it was you debate. It was which you and the pressure we use for history. Okay, do you hear me, Dr. Pratibha?
Yes, yes, sir. Yes, sir. Yes, sir.
Okay. Okay. So what happened is that in the preliminary early development of hysteroscopy, some experts at that time, they put guidelines and rules that the fluid pressure should not exceed certain level, which is 100 millimeter mercury.
Yes.
Assuming that if you exceed that limit, there will be more absorption of fluid and fluid overload and the problem of fluid overload. I regret that this concept is absolutely wrong, and I can say even ridiculous. Let us differentiate between hysteroscopy and intrauterine surgery. Hysteroscopy is to do diagnostic, small polyp, missed IUCD, little adhesions. For this procedure, you don't need a higher pressure, just distend or separate the uterine walls to see and get the pathology quickly.
Yes.
But if you are talking about a myoma, a big septum, an Asherman, this is something different, something else. And I think this is my contribution. I'm very proud that once I was introduced in the AHL said hysteroscopy before Osama and after Osama. I put a concept, okay? This is an intrauterine surgery. Different tools, different equipment, different uterine distension, different skills, different complications. If you want to apply the rules of hysteroscopy, which is keep the pressure low, if you want to apply it on the intrauterine surgery, you will never be able to do it.
Yes.
How you cut into a myoma with a pressure less than 100? Once you cut, the blood vessels will open. If the pressure inside the vessels, 120/80, this is your blood pressure. If the pressure inside the uterus is less, some trickling of blood will happen. It is not a massive bleeding. Little blood mixing with the fluid. So this is a strawberry juice. Yeah. Everything is red. Yeah. You'll not be able to continue the surgery. So you have to exceed and tamponate the bleeder, and you have to finish in a short time. About the worry of fluid overload, it is not basically because of the pressure. It's because of the time, duration, and volume of fluid. So in my concept, which looks strange, and it took a long time to convince people, my concept, working with a low pressure for a long time using large volume is more dangerous than working with the high pressure. And I'm very proud that some of the intelligent faculty like Hafiz Rahman and Dr. Kickstein in Germany, they said, Osama Shawki technique with high pressure leads to less fluid absorption. Less. Why? Because when you increase the pressure, you tamper the vessels. You close the vessel. So there's no absorption. The absorption happens when you work with a low pressure and the vessels are open. So I think I told you, number one revolution is the design and the shape of instruments. Number two is the introduction of fluid distension. And now all companies adopt my concept. They increase the pressure of the machine and they stop production of the machine. And number three revolution is my traveling all over the world, teaching everybody in 81 countries, 168 training program in India alone, more than 5,000 surgeries done. I am proud that I shake hand, I touch the hand of every gynecologist in India.
Yeah, definitely, sir. Definitely, sir. Sir, you have, I mean, you have taught so many people. Even I am one of your students, and I have learned from you. And I just want to ask you, till how much pressure you can increase? I mean, is there any higher limit to, after that you should not increase the pressure, or how we will know that?
Dr. Pratibha, the limit is for the volume and duration. Okay. This is the limit, okay? You can work with a low pressure for 2 hours and the patient will die, okay? So there is no machine in the whole market can tell you the actual intrauterine pressure.
Okay.
No company has made a mistake. It is not like the pneumoperitoneum insufflator. No, because the uterus is not a closed cavity. There is leakage from the cervix and leakage from the fallopian tube. The pressure you read is on the machine, on the dial of the machine. The machine says 80 or 200, but inside the uterus, you cannot know. The only clue to tell you about the number of the pressure, if you are operating inside the uterus, if you start to cut and there is some trickling of blood from the tissues, this means that you are below the arterial blood pressure. Yeah. If you start to cut and there is no bleeding, that your pressure is higher and tamponating the vessel. This is the only clue. But what I advise everybody, because you know, Pratibha, there are some faculties, big fight in the world, they were raising panic about the pressure and calling Osama is a crazy man, he's a showman, he's using a high pressure. This is all ridiculous. What you should focus upon is not the pressure number, but you focus on the volume of fluid you use, the deficit, how much in, how much out.
Yes.
Okay, this is the important thing. So you can do myoma resection in 15 minutes with the pressure. Machine will tell you pressure 200, but inside the uterus it could be hardly 110. Okay, you can finish it in 15 minutes, patient recovers safely. If you put the pressure to 80 or 70 and keep working inside the uterus for 2 hours, the fluid overload will be very high.
But sir, sometimes what we see, once we have done the surgery and when the pressure goes down, there is a bleeding. So how we can stop that?
I am very happy with this question, because this is also another huge misunderstanding.
Yeah, misconception. That is what is the misconception.
Yeah, misconception. Can I say something, please? A little bit irritating. Okay. Out of 10 expert laparoscopy, 10 of 10 they are really an expert. They understand very well. Yeah. Out of 10 hysteroscopy expert, 2 or 3 are really experts. Okay, I'm sorry to say that. Okay, let's now speak about bleeding, because I see many lectures, faculty saying complications of laparoscopy, hysteroscopy, and they mention bleeding. And I always say there is nothing called bleeding in hysteroscopy at all. Even you see pumping fountains of blood after you remove the septum or you remove the myoma, you see gush of blood. Let me tell you a little story. Pratibha, if you are doing vaginal delivery to the daughter of your colleague, who is a cardiologist, okay? And you say push, 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 and the baby came, and the placenta came. After the placenta, gush of blood. What will happen to your cardiologist colleague? He will collapse, okay? What will happen to you? It's normal, okay? This is the same situation of bleeding in hysteroscopy. After you finish the surgery, there is sudden gush of blood, then the uterus contracts. And this will stop any bleeding. After delivery of the placenta, the placental bed sinuses are terrible. They are 10 times more than the hysteroscopy bleeding. But to be honest, I tell you a little story happened with me in Jodhpur. I was operating with Dr. Sushila Sainai. You know her?
Yes.
And Sushila brought for me a huge submucous fibroid, posterior wall fibroid. So, and there was a lot of doctors watching me, and I was cutting, tack, come on, and the myoma finished. Beautiful view, no bleeding. And the base of the myoma was very clean. So I wanted just to make a joke and with the doctors to test their nerves. So I said, come on, do you want to see some bleeding? I said, there is no bleeding, sir. I decreased the fluid pressure. And then fountains of fountains of blood. I was just showing off in front of them that no worry, all right? I said, don't worry, trust me. This will stop immediately. I left the operating room. I went to have coffee, And then after 2 minutes, Sushila came, Dr. Usama, please come back. We have a problem. The patient is bleeding severely. I said, come on, you are still young. Trust me. Then I went to the operating room and I was surprised. There was a massive bleeding, like postpartum hemorrhage. I was shaken. I lost my confidence. Come on, I always say it will stop. And then I told, bring me the hysteroscope again. I will go again to cauterize. Said, okay, sir, the resectoscope is in the sterilization. We have to wait 10 minutes. I was worried about the patient. So I did bimanual compression, just to compress, same like postpartum hemorrhage. And while doing that, I looked to the monitor to check the vital sign, the pulse and blood pressure. And here I saw the surprise. The blood pressure was 190 over 130. So I shouted to the anesthesia, why you didn't tell me that she has a high blood pressure? He said, sir, I thought it's none of your business. I said, no, it is my business, because the hemostasis depends on contraction of the uterus and the blood pressure. So I kept doing bimanual compression for about 3-4 minutes. They brought for me the resectoscope. I removed my hands, not a single drop of blood, because the blood pressure was low down. Not a single drop of blood.
Yes.
Here, the question I ask you, Pratibha, should I go again by the hysteroscope to inspect or no touch?
No, if there's no bleeding, I don't think so. You need to go again.
Exactly. Now, if I go again and I distend the uterus, the blood vessels will. But this story to tell you that is in normotensive with good coagulation profile, whatever the bleeding, it will stop. No need for cauterization.
So what you want to, you have trained so many gynecologists worldwide. Now, what essential skill one must master to become an expert hysteroscopist? One skill,
This is a very important question, because every gynecologist, mostly they do laparoscopy well, and then they think, if I am good at laparoscopy, then hysteroscopy is easier. And this is a very big misconception. Cricket and golf and baseball, they are both have a bat and a ball. But if I bring Sachin Tandulwadkar, you know Sachin Tandulwadkar?
Yes.
If I bring him to play golf, he will not be able to.
Yes.
Okay. So he's good with the bat. Okay. So the laparoscopy skills and movement is from the shoulder, from the elbow, and from the hand. This is the laparoscopy. And the movement is big. Okay. In hysteroscopy, the whole movement is only from the wrist and tip of fingers. Only. And it is very, very smooth, very fine, very slow.
Yes.
And when you want to teach a student for laparoscopy, if he stand next to me and he see my hand movement, he can replicate. But in hysteroscopy, he cannot see your movement. That's why my technique of teaching is hands-on. I put my hand in your hand and I move your hand so you can feel.
Yeah.
And this remind me with a very nice joke. In India, I was operating once and I heard people say, you are a magician.
Yes.
Jadugar.
That was the next question I wanted to ask you. That you are a magician. And how you have developed such magic? Yeah.
No, it's not how, it's why they call me magician. Not because I am very skillful. No. I'll tell you why. There is a secret behind this. In laparoscopy, you see Hafiz or Prakash Trivedi using the harmonic or the ligature, and you see on the monitor the translation of his hand movement, okay? But in hysteroscopy, they see on the monitor some movement, but my hand is not moving.
Yes.
They don't see the movement of my hand because very fine. So they, Jadugar, okay? Jadugar, because the movement in the hand, they cannot see how he can do that, right? So it's all in the very fine movement. So it takes a lot of time to train a gynecologist to move from the laparoscopy mode to the hysteroscopy mode.
But definitely,
This
sir,
movement is very fine.
both expertise should be there, hysteroscopy as well as laparoscopy. A gynecologist should know both things. Yeah.
But they are different. He should know that they are different skills, different movement, different sensation.
Yes.
Yeah.
Definitely. So, sir, enough of hysteroscopy. Now, the thing is, what I wanted to know, is there any shift of your focus or passion from hysteroscopy to any other field apart from hysteroscopy? You are shifting to something else, or you want to exploring something?
Yes, for your podcast, I will confess some secrets, okay? That I didn't say before, all right? Okay. It's a little bit embarrassing to me to say how I failed in other things and why I failed and what lesson I learned, okay? I always teach, if you can drive a scooter very well, and you are very good at scooter, and then you see somebody driving a bullet in field, which is very attractive, okay? It is very tempting that you want to drive the bullet in field, okay? If you didn't get enough training, you will make an accident. So this happened with me, okay? I call myself a doctor of the uterus. I do only uterus, and I'm very happy with that. I can do miracles with that. And then when I was attending with Shailesh Puntamakar, okay? Yes. I saw he's dissecting the retroperitoneal and the iliac vessel, the aorta, the lymph nodes. I felt very jealous, okay? And then my son is assisting me. My son also learned these techniques. Yes. My son is very good laparoscopic surgeon. So I felt jealous from my son and from Shailesh. I said, come on, I am the best hands in hysteroscopy, so I can do the same like them. Why not? And it was catastrophic, okay? It was disastrous, all right? I did it very bad. And some bleeding. I was afraid because bleeding next to the ureter. So I said, come on, if I want to do it well, I have to spend the same time like Shailesh, like my son, to be good. So this is my advice for all beginners. You can be a hero, but not only by imagination or by just, I can do it. No. Yeah. You have to spend the time and the effort and the training. So after I failed in laparoscopic oncology, I said, come on, I'll go back to my playground. I am Sachin Tandulwadkar. I am Shah Rukh Khan in my uterus. Definitely. So inside the uterus, I have so many temptations. Some people want to pull my leg in aesthetic gynecology. I said, no, I am only man of the cavity of the uterus. So for gynecology, I am not interested to go beyond the borders of my kingdom.
Definitely, sir. But there are saying, I just want to ask you also that people say that for laparoscopy, you have a longer learning curve, whereas for hysteroscopy, you can learn very early. What is your opinion about that?
Actually, I was in Pune with Hafiz and Shailesh. We had a big conference there with the AGL. And I will repeat what Hafiz said in his lecture. Yeah. Okay? Hafiz said like that. I need 5 days to teach a student, 5 days to perfect TLH. Okay. In 5 days, because insertion of the trocar is easy. Mm. The steps of the procedure is the same like open. Okay, dissection of the bladder, the round ligament. So it is the same steps. All you need is the synchronization of the hand movement and the suturing technique. So he said, I need 5 days. But Hafiz said, but I cannot apply this on myoma resection. Hysteroscopic myoma resection, you cannot master it in 5 days. Yeah. You cannot master septum in 1 year. All right? The insertion of the hysteroscope, this journey is much, much more difficult than the trocar. And I confess another secret, Pratibha. 50% of cases referred to me as an Asher man it is not an Asherman. It was false track,
False track.
right?
Yeah.
False track. So, and most of them, they have a norm, but because of failure of entry, the doctor made a false track, all right?
Yeah.
So this is what it is very wrong concept that hysteroscopy is easy. Laparoscopy, you work in a big cavity, insufflated well,
Yes.
you have 1, 2, 3, 4 instruments, you have a uterine manipulator, you have a cameraman.
Yeah.
And you have an assistant hand in hysteroscopy, you work in a very small cavity, difficult distension, one instrument, no assistant, no cameraman.
Yes.
So it is much
So you
high skills. But
require skill and
what
you require
makes people-
training time. Yes.
I tell you another secret also. I'm now in a mood of honesty, all right? All laparoscopy complications are scandals. It's scandalous. I mean, it is exposed. If you go to do laparoscopic hysterectomy and you failed, it's a scandal. You're open. If you do bleeding, anybody watching you, he knows that you are bad, okay? So it's scandalous. And most hysteroscopy complications are hidden. Nobody will know it happened, okay? Nobody will. You go to do septum and you don't finish it.
Yeah.
Oh, come on. I did it.
Yes.
And it come back again. I'm sorry. This is okay. Right. You go to do Asherman. You added more adhesions, okay? And nobody will know. One more thing. If 10 students are attending an expert in laparoscopy doing TLH, they can judge if he's an expert or not, okay? Because they know hysterectomy. They know the anatomy.
Yeah.
They know that this is the ovary, this is the infundibly perfectly. They know that there is bleeding from the uterine. But if the 10 students attending a surgeon doing Asherman,
Yeah.
what is this, all right? They don't know if he's in the proper plane or not. If they're watching a septum, they will not judge if he did it correct or not. So that's what makes people say it's easy. Because the judgment about it's expertise, okay? It's very difficult to know if the performance is good or not. But I'm very glad I have now 4,000 videos on YouTube. Everybody can watch, everybody can learn, everybody can compare.
Yeah, definitely, sir. So you require a lot of expertise. Now, sir, you have trained so many gynecologists worldwide. What has been the most fulfilling aspect of teaching? What did you find? That
you mean the most
other
rewarding
people
for me?
follow us? I mean, there are a lot of people who are following our hysteroscopy. Hysteroscopy is becoming more popular.
You know,
and people are taking it as a, I mean, it's previously people, they wanted to be a laparoscopic surgeon rather than a hysteroscopist. So what is your opinion?
no, Pratibha, there are certain things I'm proud in my life. Number one is the shift. I could shift the attraction, the attention, and the glamour from above, from the laparoscopy, to be hysteroscopy. And you know, Pratibha, one more secret. You know what helped me in that? What helped me in that is the development of IVF and assisted reproduction.
Yeah.
All these centers, they became interested about the uterine cavity.
Yeah. Yeah.
You know, Pratibha, in the old times, they were doing much laparoscopy for infertility. Tuboplasty, salpingolysis, blah, blah, blah. Not anymore now. So now the cavity became more important. So if you look at the conferences, the congresses, and the journals, in the past, most of the articles and the presentation was only laparoscopy. Now it is 50-50. Even hysteroscopy is getting more crowd.
Yeah.
I'm proud that in AISOG, the whole for my lecture, people are standing, okay?
Yeah.
So we could pull the attention to the cavity of this. My second pride is when I'm somewhere in the world or traveling many times, people stop me in the airport. Hi, Dr. Shauki, I am a gynecologist. I met you in Taiwan. I met you in Australia. And I learned from you. You don't imagine my heart pumping of happiness. When somebody said, because of you, I became an artist. I love it. I enjoy it. And even some of them, they say, yes, we do laparoscopy very well, but we enjoy more when we do the hysteroscopy the way you teach us. So it is very rewarding when I see people doing better, achieving better, and helping patients much, much better.
With a much easier, it is very easy. If you don't need any, it is a no whole surgeries like you can do. It's like that. Anyway, sir, I want to ask you that what is the biggest lesson you have learned throughout your journey in this hysteroscopy? Any lesson?
Well, it is not a lesson, it is a philosophy that I absorb, okay? Pratibha, maybe you and everybody listening to me now has forgotten 9 months of your life you lived in this small room.
Yes.
In this small room, we enjoyed the best time of our life. We were excluded from the outer world. Whatever happening outside, violence, wars, we are in peace.
Yeah.
Whatever it is, freezing cold or very hot, we are in this 37-degree jacuzzi.
Yes.
And sleeping on the soft pillow, the placenta, and listening to the music of my mother heart rate, entertaining me, okay? And that's why when the clock ticks after 9 months and you are kicked out, the first thing you have done that you cried. But Osama didn't cry. Osama said, I will be back. I will be back to the greatest temple, to be the servant of this temple, to keep it clean, to keep it prosperous, to keep it fertile, to receive the seeds and bring more and more generations for humanity. So the lesson I learned from working all my life inside this, and you know, Pradeep, every time I enter the uterus, it's a new experience. Don't think it is boring. No.
Yeah.
It is not like open surgery. Every time I see something new, the endometrium is not the same.
Sir, how
The
you
cavity
became
is
so
not
interested? How you became so interested in hysteroscopy? Just because you had a love for uterus, or it's something we are also a gynecologist.
I tell you.
Yeah.
For every one of us, when we enter the body, you get attracted to some part. Some people love the abdominal cavity, some people that the liver or the heart, or they came passion. Some people love the eye, became ophthalmologist. But the moment I entered the uterus, I was mesmerized because I've never seen it before, okay? In laparoscopy, this is the same cavity that I entered several times before when I did ovarian cyst. But the cavity for this was new for me. One more thing. When I entered the cavity of the uterus, I felt that I am the only one in the world who have explored this cave. Nobody entered before me. You understand what I say, okay? So I felt that I'm the only one. This is my treasure. This is my area that I will introduce the whole world to see it. You understand? Yeah. So this give me a passion and give me a motive. I want to do more. I want to make it better. I want to let people see it, okay? Same like a person for the first time, he visit India, okay? Somebody from United States or from Europe. Oh, it's another world, okay? But if the American person visit Europe, it's normal, okay? So this is the same about laparoscopic surgeon, okay? The abdomen is same, but look at Munar, Taj Mahal, okay, Rajasthan, okay, it's something new, okay? So I felt that I will introduce the whole world to a new invention.
So I know that you have to be remembered as a hysteroscopy expert, or you want to be remembered any other way?
This is an important question because apart from being a gynecologist and hysteroscopist, I think you know about me when I'm visiting every place in India. I start my lecture by a motivational speech, talk, trying to build confidence, faith in the heart of everyone that you are able to achieve and to reach your dream. And that what you call it talented or expert is just repetition of an action to make you expert. So I am here to help you to reach your dream.
Yes.
Not only in hysteroscopy. So hysteroscopy is a little tool from my ambitious trying to make others happier and more success. So about to be remembered, in fact, it is not important to be remembered at all. But what is important that somebody after me will live and enjoy and can make somebody else more happy. If I make one doctor successful and talented, he will help a patient. And the patient will be happy. And the family will be happy. So what I dream about is, look at the great Mahatma Gandhi. Did he enjoy life? No. He didn't enjoy. He didn't enjoy. Did he care that people will say the great Mahatma Gandhi? No. He didn't focus on that. But his effect, his spirit is living within us. I tell you something. The greatest novelist writer, Russian, his name is Lev Tolstoy. Do you know the name?
Yeah.
Lev Tolstoy. He's a great human being. Great Tolstoy said that my biggest admiration in my life was the Mahatma Gandhi. So Gandhi from India inspired Tolstoy in Russia, and Tolstoy inspired Martin Luther King in America. So Martin Luther King was inspired by Lev Tolstoy, and Lev Tolstoy was inspired by the Gandhi, but none of them know each other or remember each other.
Yeah.
So what I dream that people will be happier because of something that I did for them, whether they remember me or not.
Yeah.
And you know, Pratibha, many
You will
people
be
copy my
definitely
work.
remembered like a magician. Yes, we have seen your hysteroscopy skill and we have seen your videos. They are really lovely.
Thank you. Thank you.
So, sir, what advice will you give to the young gynecologist about sustaining this enthusiasm and cultivating this
Okay.
procedure, this expertise?
For any young person, doctor or non-doctor, first, you have to find and to decide your goal, your dream. You want to be an accountant, an engineer, a businessman, you want to be a doctor, a gynecologist first, and then have a faith and trust that the most successful person in this field is not better than you. Mukesh Ambani is not better than me. Sachin Tandulwadkar is not better than me, but they worked hard. Shah Rukh Khan, for his age, to keep his muscle and form, he is exercising every day, every hour. So, nobody is better than you. Have just to drive and walk the same road.
Yes.
And please stop believing in lose your body weight in 5 days diet. Learn English in 1 week. This is fake. Okay? Be smart by attending workshop with Osama, you will be good history. This is fake. So my advice, have a passion, work hard for your dream, and definitely you will reach the stars. And even if you're not lucky to reach the top stars, at least you will land on the moon.
Yeah.
So this is my advice for everyone. And be good in your heart.
Yeah.
Whatever skills you have, whatever science you have, if your heart is not pure, you will fail.
Yes.
And I'm sure you know many examples of great surgeons, great doctors, scientists, but they are miserable in their life. Nobody loves them. Nobody wants to be with them. And their family they're not happy with their wives or their husbands, okay? So the purpose is not to be great in your profession, but to be great as a human. And remember that the success of others and the happiness of others does not take from your own account.
Yeah.
So stop being envious. Stop being attacked to great icons, okay? Not because he's happy means that you should be sad. No, don't be bad to others. Have a good heart, have a passion, and enjoy and live your life with the concept, me and you, not either me or you.
Or you. Definitely, sir. Very important lesson you have told us. It is important that we should have passion and we should know how much you can do and how much expertise you can attain. That is also important. Everybody cannot reach up to the sky, but at least we can land on moon. That is what you said, and I'm really happy that you are giving such important lessons to us. Now, sir, if not hysteroscopy, what other field would you have persuaded? Just a controversial question.
I have been asked this question many times because my followers, by the way, in the Facebook, every day I check how many people visit my page. So today I found 15 million people visiting my page because of my article. It's not about hysteroscopy, about many things.
Yeah.
So people were thinking, if you're not a doctor, what do you like to be? My dream was to be a pilot. My dream was to be a fashion
And
designer.
I know, sir, that he wanted to be a pilot. Yes.
Yes, a fashion designer,
Okay.
a singer, a poet.
Very good.
Anything that can make other people happy. To sing for them, to write poem for them, to anything to make people happy. Because I believe I charge my happiness from others. You know, when I see that people around me, I think you visited me in my home, in my country.
Yes, sir. Yeah.
And you have seen that I worked as a tour guide. Okay, I was enjoying to be your tour guide.
Right? Yes, sir. Definitely. So it was very good, and we really enjoyed your house and everything. And it was a warm welcome which we got at your place. And
come again, please.
Definitely, sir. And can you tell me what final message you want to give to our medical professionals to take up this subject, or to have expertise in hysteroscopy, or what message you want to give to our medical experts?
The message is a very important political message, okay? Political means we live in an era controlled by authorities which put guidelines, papers, publications, okay? And this what are the young people follow. These are the torchlight, okay?
Yes.
What I say, read, read, read. But only believe what you see by your eyes, not by you listen by your ears. Okay? So now, or in the past, it was difficult that the young people can reach to the expert. You cannot, at the time of Vertime, not every doctor from India can travel to Germany to watch Vertime. And at the time of Shirodkar, not everybody can travel to India to see Shirodkar working, okay? But now, everything is available on the internet.
Yes.
There are videos, operations, live surgery, traveling is easy. If I hear that somebody called Childish Puntamaker was able to do uterine transplant, it only cost me a flight ticket to Pune, and I go to watch him, all right? I don't want Childish to tell me, blah, blah, blah. No, I want to see you, all right? Okay, I learned a lot. Not only, this is the final message to everybody. The great surgeons are not great because of their hands, because of their mind, their attitude. And this we will not learn in the Congress room, in the lecture. You have to be with him. Yeah. So I learned from Hafiz, I learned from Sharish, not hysteroscopy, but attitude. I tell you last story, for example. With Hafiz Rahman, we were operating in Delhi one day, and it was live surgery. Live surgery, broadcasting to all over the country. I was in my room doing myoma resection, and Hafiz was doing hysterectomy, lymphadenectomy for a cancer uterus. And while I was operating, I heard the noise. Everybody was running. And Nikita Trahan was panicked and running. I said, Nikita, what is wrong? She said, we have injury to the aorta. I myself, I was doing like this. Okay, I was doing like this. Although I'm not the surgeon, okay? But to feel that in the next room, the aorta is pumping blood, I was like that, okay? So I quickly finished the myoma resection. I jumped to Hafiz to help him. And in this room, I learned the attitude of Hafiz Rahman. He was very calm, giving instructions to the team, do this, do that, do that. And quickly, he was handling the case. I told him, Hafiz, should we cut the transmission now? I don't want the people to see the fountain of blood.
Yeah.
He said, no, leave it going on. I want them to see how complications can happen with the expert. That will give them more confidence and let them see more important, not just TLH, but how we handle. They will not see this in their life again.
Yes, definitely.
I admired his attitude of calm, tranquil, and I swear to God, in 20 minutes, but we did open actually, we did open. In 20 minutes, the aorta was repaired, patient was fine, and transferred to her room without ICU, without blood transfusion. I learned. So my advice to everyone, every person you meet in your life is a school, is a college, but choose. Don't choose anybody, okay? Choose. Okay. Rabindranath Tagore was my teacher. I learned I put line under his books. The Mahatma Gandhi was my teacher, and I was inspired by him. I said, this man moved all over India walking with his stick to spread the principles of love and peace. I want to do the same. So I rumbled all over India with my stick, which was the hysteroscope, to spread also principles of love and friendship and peace. So my last advice, please don't learn only from textbook. Every person around you is another school. I learned from Sunita Tandulwadkar, but I will not mention the story. Sunita was an excellent teacher for me in her attitude as well. So I hope everybody get benefit from my talk, and it will help him to develop himself in his career and his life.
So thank you, sir. Thank you so much. It was indeed a very informative podcast where we gained invaluable insights and learned so much. And now as we wrap up, I would like to extend my heartfelt thanks to our esteemed guest, Dr. Osama Shauki, sir, for so generously sharing his expertise in hysteroscopy. His guidance will undoubtedly inspire and will help us to build a skill in the younger generation gynecologists. A special thanks to all our listeners, viewers, and audiences for tuning in and being a part of this enriching experience. I would also like to express my deep gratitude to Dr. Sunita Tandulwadkar, ma'am, for her visionary leadership and commitments to fostering academic discussion like this. And it is through such initiative that we continue to elevate our standards and stay updated in ever-evolving field of hysteroscopy. So thank you once again, and until we meet next, let's keep learning, growing, and striving towards a healthier tomorrow. Thank you so much, sir, for being here and sparing a valuable time with us. Thank you so much.
Thank you, Dr. Pratibha, and my best wishes to each and everyone listening to us now, and to all Foxians and to all beautiful colleagues in your country. And I finish by saying your country is a great nation, not because you have oil or you have money or computers or weapons. No, the greatness of your nation is the people. Those people who were icons in the history, inspiring all the civilizations by their wisdom. So keep this wisdom in your mind, in your heart, and inspire more and more the world. Thank you.
We are really honored, sir. We are really honored. Thank you so much. Thank you so much. Okay.